I'd like to introduce our first set of speakers who will be giving us an overview of some Medicaid updates. And in this block, we'll hear from Stacey Smith, who is a behavioral health policy analyst with the Division of Health Benefits, Starleen Scott-Robbins, Special Populations Team Lead and Women's Services Coordinator with the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, and also Denise Baker, Team Lead for Legislative and Regulatory Affairs with the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. So it's wonderful to have you all with us today, and with that, I'll pass it to Stacey to kick us off.
Thanks so much, Amanda. Just a little update last minute. Denise is not going to be able to make it today. She had something come up that she had to take care of. So you all are stuck with just me and Starleen, but we will do our best to share lots of great information with you all. And I'm going to turn my camera off to keep bandwidth low while I'm presenting, and then work on getting this set up. Ooh. Sorry, I'm not as used to Zoom. Oh, need to switch. All right, I'm going to hope that everyone is able to see the slide, cover slide.
Yes, we can.
Awesome, thank you. I also realized as I asked that I couldn't see chat. So if folks were putting it in chat, I'd be a little bit out of luck. So Starleen and I today are going to talk about expanding and strengthening the North Carolina Substance Use Service Array through the North Carolina 1115 Substance Use Disorder Demonstration Waiver. We are going to review the factors that fueled the development of the 1115 Substance Use Demonstration Waiver, the 6 milestones that the waiver addresses, and then also discuss the impact these 6 milestones will have on the North Carolina Substance Use Service System. We will also be reviewing and discussing how the 1115 Substance Use Waiver work will help the state and providers better support individuals that have opioid use disorder. So back in April of 2019, we received approval from CMS to implement the 1115 Substance Use Demonstration Waiver. At that point, I'm sure to the group on this call, this is not a surprise that at that point, the opioid crisis was intensifying, even though there was work in place through measures like the STOP Act to try to reduce the opioid crisis and reduce the amount of overdose deaths and EDs that we were experiencing at that time. So we can see from this graph that the green line is when North Carolina launched the Opioid Action Plan. And you can see that from the beginning of the graph in 2000 through current, this graph represents unintentional overdose deaths among residents of North Carolina. You can see that it has been pretty consistently on the rise. This metric includes deaths involving all types of medication and drugs, opioids, including your commonly prescribed opioids, heroin, and synthetic narcotics like fentanyl and fentanyl analogs. Also includes stimulants, benzodiazepines, and others. This metric includes fatal overdoses of all intent, and over 90% of these deaths are unintentional. As a key opioid action plan metric, a goal was set to reduce the expected number of overdose deaths by 20% by the end of 2024. And as you can see, unfortunately, the trend has actually increased, and we've actually had a significant spike, likely related in part due to the COVID pandemic. And our rate is up at about 30.2. This graphic represents emergency department visits in North Carolina due to opioid overdose ED. The ED visits are for opioid overdose. In 2019, for every 1 drug overdose death, there were 5 emergency department visits due to overdose in North Carolina. These ED visits were excuse me, are limited to unintentional and undetermined intent cases only, and overdose codes of drugs and medications with dependency potential. There was also a goal with this metric to reduce the expected number of overdose ED visits by 20% by the end of 2024. Also important and related to this chart is we know that in 2020, more than 70% of overdose deaths likely involved illicitly manufactured fentanyl. And we also know that there are instances where individuals are unknowingly taking fentanyl because it has been mixed in with other substances that they're using. So that's really a concerning percent, 70% involve fentanyl. As you can see in this chart, again, we experienced an increase in ED visits related to opioid overdoses. And then we also had the increase in opioid overdose deaths on the other slide. Again, there's a spike where we see the COVID pandemic occurred, and we anticipate that that played a role in the increase. From an equity lens, the three ethnicities that are most impacted by overdose deaths are Black Americans at a rate of 26.7 individuals per 100,000, White Americans at a rate of 36.1 individuals per 100,000, and the ethnicity most significantly impacted by overdose deaths are Native Americans at a rate of 83.6% per 100,000 individuals. We also know that this contrasts with what we know about access to treatment. Research finds that nationally, individuals that are adolescent, uninsured, Black, Native Hawaiian or Pacific Islanders or Asian Americans are most likely to underutilize opioid-specific treatment. The treatment rate for Black Americans was less than 4%, and adolescents are unlikely to use or receive medication-assisted treatment for opioid use disorder unless they're engaged in the criminal justice system. Finally, we all know that rural areas where we often see a higher occurrence of opioid misuse often face the most significant barriers when it comes to access. Either they're being limited to no providers, or there could be providers in the area, but just navigating the transportation issue is a barrier in and of itself. So these are the things that kind of fed into the development of the 1115 substance use demonstration waiver and why we're continuing to push for full implementation of this. The 1115 substance use demonstration waiver allows North Carolina to expand the service array. Once fully implemented, Medicaid beneficiaries will have access to all Asam levels of care, and Medicaid will provide reimbursement for services when they are medically and clinically necessary. It will bring new levels of community-based care into the state, as well as several new residential levels of care. Some substance use services will be developed to work with both adults and adolescents, ensuring that we have services to support adolescents in their recovery and ideally lessen the chance of substance use continuing into adulthood. However, to truly and fully expand access, Medicaid expansion is required. We know that as Medicaid is currently managed in the state, very few beneficiaries that have a substance use disorder only have Medicaid, and typically the individuals that have it are either adolescents or pregnant and parenting women. We did just have an expansion of pregnant and parenting women coverage for Medicaid, where the women are able to continue to receive Medicaid for, I believe, 12 months, whereas before it was shorter. So that's a huge gain. However, if you are an adult and if you are male, or if you are an adult woman that doesn't have children, and your primary diagnosis is substance use, and you don't meet the financial criteria, we know it's unlikely that you have access to Medicaid. Not only would Medicaid expansion provide additional coverage or provide coverage to additional North Carolinians, which would increase the number of adult beneficiaries diagnosed with a substance use disorder that have Medicaid. It would also support providers that are providing those services, because we realize that often folks seek treatment, but they don't have insurance to cover the treatment. And we know that state funds are limited for uninsured individuals. Expanding Medicaid would take some strain off of that, because we would anticipate some individuals that currently don't qualify for Medicaid could qualify for Medicaid, and then they wouldn't be seeking services under state funds. And one thing that we do know consistently is state funding is cut from year to year, which makes it more difficult for individuals without insurance to access the services they need for the length of time that they need it. This slide shows what services are covered by standard plans and tailored plans, and it also shows what services are exclusively covered by tailored plans. Our current standard plan vendors include AmeriHealth Caritas, Healthy Blue, United Healthcare, WellCare, and Carolina's Complete Health. Our future tailored plans are Trillium Health, East Point, Alliance Health, Sandhills, Partners, and VIA. Both standard plans and tailored plans are required to cover opioid treatment providers, the withdrawal management service array, medically managed inpatient withdrawal management, and clinical coverage policy 8A5, which is diagnostic assessment, and 8C, which is your outpatient behavioral health services. Tailored plans at this time will be solely responsible for SAIOP, SACOT, and all residential levels of care. There currently is a transfer request process to support individuals in receiving the medically and clinically appropriate level of care they need, regardless of their current plan enrollment. So if a beneficiary's Medicaid is currently managed by a standard plan, but they need SAIOP or SACOT, there is a request to transfer form and a process that will expedite the transfer of the beneficiary to a tailored plan so they can immediately receive the appropriate level of care. This process is currently in place, and it will continue to be in place when the tailored plans launch on December 1st of this year. I am not going to go in detail regarding these services and policies, as we are going to cover that in an upcoming section, and I don't want to steal Starleen's thunder on that. So the 1115 substance use demonstration waiver also gave North Carolina the authority to waive IMD exclusions for beneficiaries that receive substance use treatment. What exactly does IMD stand for? I knew I did not know what this meant until I started working for this state. So IMD stands for Institution for Mental Disease. And what that is a hospital or residential treatment facility that has more than 16 beds that are primarily engaged in providing diagnosis, treatment, or care of persons with mental diseases. It is important to note that IMD does not apply to Medicaid beneficiaries under the age of 21 or over the age of 65. This exclusion has been in place since 1965. Prior to the 1115 substance use demonstration waiver, the only way an adult between the ages of 21 to 64 could receive services in an IMD. So again, think of your hospital, your residential treatment facility with more than 16 beds, was through the use of an in lieu of service, which the LME-MCOs were responsible for developing. Even with the in lieu of services, a Medicaid beneficiary who is between the age of 21 and 64 couldn't receive more than 15 days of treatment in an IMD per month, making the maximum length of stay 30 days only if the 30 days were equally split across the 2 months, so no more than 15 days in each month. If any stay exceeded 15 days per a month, the entire length of treatment would not be reimbursable by Medicaid funds. So for example, if you had an individual that needed to go to community psychiatric hospital, I'm in Wake County, so Holly Hill is the one that I think of. If you had an individual that had to go to Holly Hill because they medically and clinically needed that level of care, and they were an adult between the age of 21 to 65, if their length of stay exceeded 15 days in one calendar month, Medicaid would not reimburse for that treatment. Through the 1115 substance use demonstration waiver, we waived the IMD exclusion for all substance use services. By waiving the IMD exclusion through this 1115 demonstration waiver, beneficiaries will be able to receive services in a setting that is considered an IMD, and Medicaid funds will reimburse for the full length and cost of treatment. This also means that residential facilities could have more than 16 beds, and beneficiaries can receive more than 15 days of treatment in a setting considered an IMD in a month. This will ensure that treatment is guided by beneficiary need, medical and clinical necessity, and the person-centered treatment plan, instead of by what will be reimbursed or what won't be reimbursed. And not only does this have an impact on residential facilities being able to go above 16 beds, this also directly applies to Asam levels 4 and 4WM, which are provided in a hospital setting. If a beneficiary needs more than 15 days of care in a level, Asam level 4 or 4WM, Medicaid will be able to reimburse for the full length of that visit. And with that, I'm going to turn it over to Starleen.
Thank you, Stacey. Can you hear me okay?
Yep.
Thank you. So I am going to walk you through Milestone 1. And Milestone 1 of the 1115 SUD demonstration waiver is the expansion of SUD benefits to offer the complete Asam continuum of care. Next. So I am grateful to Stacey because she always lets me do the really cool part of this this presentation, because I get to share with you some of the pretty innovative things that are happening within policy, both in Medicaid and state-funded services, starting with the fact that medication-assisted treatment will be required at all levels of care, including residential, to ensure that individuals have access to needed services. This requirement means that in order to bill for state or Medicaid SUD services, the provider is required to provide or arrange for access to MAT for substance use disorders. This includes the withdrawal management, outpatient, intensive outpatient, partial hospitalization levels, as well as residential. Providers that do not have MAT on site for their services will be required to have the ability to link to individuals to licensed opioid treatment programs or to an office-based buprenorphine outpatient provider. Next, please. From 2000 to 2020, more than 28,000 North Carolinians lost their lives to drug overdose. Providers must be prepared and equipped to address the opioid overdose problem in North Carolina. As a result, each of the policies that are being implemented will be required at the residential level to have access to on-site naloxone and provide training to staff in the use of naloxone. This requirement will support the training and access to this life-saving medication. As we know, with what Stacey talked about earlier in terms of the overdose the problem in North Carolina continuing to increase, we must make sure that our providers have the support they need to address overdose as a part of their ongoing work with individuals who are seeking treatment. Next. What are we doing to push for harm reduction and policy development? Access to MAT is required at all levels of residential, including MAT must be provided or arranged for levels Asam 3.1, 3.3, 3.5, and 3.7. And how we are making access to for MAT to happen at a residential setting is we're including in policy a medication-assisted treatment organizer, a position that will coordinate MAT appointments and facilitate transportation to scheduled MAT appointments for individuals. They will collaborate with the medical staff and program managers to ensure information regarding MAT is reflected in the individual's PCP and clinical record. They will organize, coordinate, and monitor all MAT and physical health appointments, ensure that all individuals eligible to receive MAT have transportation to and from the MAT administration site, which includes direct facilitation of transportation, ensure safe and secure transportation of any prescribed medications from the MAT provider to the residential program, and coordinate exchange of information between MAT staff to the actual program and clinical staff. So this is a brand new position that's being added to these residential levels of care. It is also incorporating transportation, the support and payment of transportation for this particular activity, which is very different for Medicaid because usually Medicaid transportation is utilized separately from one of the clinical services. So this is really an effort to ensure that people have the access to MAT and to physical health appointments as they are addressing their SUD treatment needs in a residential setting. Next, please. Additionally, we know that people with lived experience have a very important role to play as a part of the treatment experience. In that regard, peers will either be a part of the required staffing for programs, or individuals will be able to access peer support services from external behavioral health providers. Peers will be required to be certified through the North Carolina certification program at UNC School of Social Work, and programs will need to be mindful in hiring peers for the special populations they may be serving, including peers with TBI and substance use, peers that have experience with pregnancy and substance use, or even peers working with adolescents. Next slide, please. As a part of whole person care, we must also support individuals in addressing their reproductive and sexual health, particularly in early recovery. Reproductive life planning and sexual health education will be provided by all residential providers. Reproductive life planning, this is about empowering individuals to make informed choices about their reproductive and sexual health. The Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, in collaboration with the Division of Public Health, have developed and delivered reproductive life planning education and training over the past 3 years. All of the perinatal maternal CASA Works programs in the state initiative are required to provide reproductive life planning, education, and referral for resources when applicable. Over 20 opioid treatment programs have also received training, and more recently, all of the Oxford House regional staff have been trained to provide reproductive life planning and sexual health education as well. A reproductive life plan is a set of goals that people make about childbearing. It takes into account the who, what, when, where, why, and even if of family planning. It's not set in stone, and it is meant to be a very fluid training and education process. The expected benefits of reproductive life planning include increased preconception planning, improved reproductive health, improved birth outcomes, improved health-related knowledge, and increased healthy behaviors. The what is a really important piece here. This is totally voluntary, and it also provides access to resources through a collaboration with the local Title 10 providers, which are usually health departments, because they support, they're supported with family planning funds that can help individuals access resources that they may include as a part of their plan. Per the CDC in 2020, in their overview, over half of reported cases of STIs were in adolescent young adults aged 15 to 24, with disparities among some racial minorities and Hispanic groups versus Hispanic white people. 32% of all cases of chlamydia, gonorrhea, and primary and secondary syphilis were among non-Hispanic Black people, even though they made up only 12% of the US population. In North Carolina, we are ranked 15th for chlamydia, 10th for gonorrhea, and 18th for primary and secondary syphilis. We must equip individuals with the education, support, and treatment that they need around their sexual health to make good decisions about how they move forward and with their sexual lifestyles. We have the opportunity to do that while people are in treatment and have the opportunity to get the education and get access to resources. We also know that anywhere from 70 to 90% of the individuals who enter SUD treatment have experienced some level of trauma in their lifetime. Individual trauma results from an event, series or events or set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. We know that trauma shapes and informs our interactions with ourselves and others and view of the world, and it has profound impact on our body, minds, and spirits. It often results in isolation, discontinuation, disconnection, learned helplessness, humiliation, shame, rage, and substance use disorders. Women who have had childhood sexual trauma are less likely to use contraceptive practices. We know that if trauma is not addressed as a part of the treatment process, that we can have folks who will continue to come back into treatment because they are not, because the trauma has not been addressed and they don't have the skills or the support that they need to continue in their recovery process. Next slide, please. Per the American College of Obstetrics and Gynecologists, an unintended pregnancy is a pregnancy not desired now or in the next 2 years. As you can see, the unintended pregnancy rate in North Carolina for the general population is slightly higher than the national rate. However, for women with an opioid use disorder receiving MAT, that rate is up to 86%. Among women with opioid use disorder in the US, 54% report having 4 or more pregnancies in their lifetime compared to 14% of the general female population. Women with an opioid use disorder are 5 times more likely to have an abortion than the general female population, and 50% of women with a substance use disorder use contraception versus 81% of women without a substance use disorder. Early recovery is a time for folks to get the information and resources that they need in order to be empowered in their decision making. And we want to use the clinical policy as a way to be able to provide that information and empower people. Next. We know that youth opioid use is directly linked to sexual risk behavior. The research has found that for young women, alcohol use is an important correlate of sexual initiation, unprotected sex, and sexually risky behavior. Education on and access to contraceptives can empower individuals to make informed decisions on contraception use. Drug use is associated with sexual risk behavior, experience of violence, and mental health and suicide risk. And we know that there's a high occurrence of women that are incarcerated that also have a substance use and interpersonal violence and STI. So again, this is a time in treatment for individuals to be able to get the education they need and access to resources to address these issues. Next slide, please. So what are we doing to push for whole person recovery focused care and policy development? Throughout the Asam criteria, it calls for services to be focused on all areas of life and health, not just to address the substance use, especially in residential programs. This is seen in the language reviewing what all programs should offer: daily scheduled professional addiction and mental health treatment services designed to develop and apply recovery skills. They may include occupational and recreational therapists, art, music, and movement therapists, physical therapists, and vocational rehabilitation services. Some of the services identified have existing clinical coverage policies under Medicaid and fee schedules in place, which would allow providers to enter into MOAs or MOUs with physical health providers, OTs, PTs, voc services. However, some of the services mentioned do not currently have a Medicaid policy to work with individuals. So we have included positions in a number of the residential programs that include licensed rec therapists with the adolescent programs, board certified music therapists, registered art therapists, and in the pregnant and parenting people's policy, we have also included a child family life specialist, which is a licensed clinician to work with the parents and their dependent children. This is unheard of in prior Medicaid policy. As a matter of fact, we were looking at, some of the other policies that are in place currently, and these level of professionals have not been in policy for Medicaid under behavioral health in the past. And so this is a real opportunity for us to see what these outcomes look like and to help support individuals who are in recovery to address the needs that they have as a part of their whole person recovery focused plan. Next, please. Again, for Milestone 1, this is about the expansion of the array of SUD services. This slide covers all of the withdrawal level services under ASAM. All of these services will be covered by both Medicaid and state funds. 2WM will be a brand new service for both Medicaid and state funded services. 3.2 WM will be a new service covered by Medicaid. This level of care is currently a covered state-funded service, also known as social setting detox. Services will either have clinical coverage policies developed or revised to align with the 2013 ASAM criteria. Next slide, please. So ASAM level 0.5, which is the screening, brief intervention, and referral to treatment. This is a public health approach to screening and early intervention to help identify, reduce, and prevent substance use disorders in people at risk for developing substance use disorders. The SBIRT CPT codes that have historically only been available to be billed by MDs and extenders will now be available to all licensed professionals under the Medicaid 8C outpatient behavioral health clinical policy. The 2 SBIRT CPT codes will be available. And in addition to that, the 8C clinical coverage policy is currently posted on the DHB website for public comment, and it includes also a change that allows for place of service to be inclusive of settings beyond primary care, including behavioral health and other community-based programs. Prior to that, you could only bill the SBIRT codes in a primary care setting. So they're also broadening the, expanding the settings that the SBIRT codes can be billed in. ASAM level 1, which are the outpatient services under ASAM. This includes changes to Medicaid's 8A, 8A5, which is the diagnostic assessment, and the comprehensive clinical assessment that is under 8C. Both of those policies are being updated to include ASAM level of care determination when the individual has a substance use disorder, and adding an ASAM training requirement to ensure that licensed professionals receive training on the utilization of ASAM criteria. In addition, individual, group, and family therapy under the 8C policy is adding the documentation of ASAM level 1 determination and ASAM parameters up for individuals receiving outpatient that require less than 9 hours a week for adults and less than 6 hours a week of outpatient services for adolescents. With ASAM level 2.1 and 2.5, intensive outpatient and partial hospitalization for North Carolina, SAIOP and SCCOT, both of those services are being updated to align with ASAM criteria as well. The opioid treatment service is probably one of the services that is changing, it has the most dramatic change. currently, the billing code for opioid treatment only covers the administration of the medication, either methadone or buprenorphine. However, the new service is a bundled service that is inclusive of the counseling, therapy, psychoeducation, care case coordination, and the medication is covered as well under the bundled service. So whether it be methadone or buprenorphine products being dispensed, they will be covered as a part of the bundled service. Next slide, please. So the residential levels of care that are covered under the waiver include ASAM 3.1, clinically managed low intensity residential treatment, and that is currently covered under the state funded services under a halfway house level of care. This will be a new service covered for Medicaid. There'll be new licensure rule and rate that will be developed. Programs must offer at least 5 hours per week of low intensity substance related disorder treatment. They can include individual, group, and family, medication management, and psychoeducation. It can be combined with intensive outpatient if the individual meets the entrance criteria for that higher level of care. And it's appropriate for individuals in the early and pre-contemplative stage of change. This level of care is not a sober house, boarding house, or a group home not providing treatment services. ASAM 3.3, clinically managed population-specific high-intensity residential services. This service does not exist currently under Medicaid or state-funded services. It is a unique level of care in the ASAM continuum, and it provides a structured recovery environment in combination with high-intensity clinical services. For North Carolina, in the 1115 waiver application, because of the work that North Carolina had been doing around the TBI waiver, North Carolina chose to make this special population individuals who have a primary substance use disorder and a traumatic brain injury. The care for this service is tailored to meet the unique needs of individuals with a substance use disorder and functional limitations due to a cognitive impairment. The functional limitations can be temporary or permanent, and a combination of the substance use and cognitive impairments are such that the individual's needs cannot be met through outpatient services or other levels of residential. North Carolina will be one of the first states in the country to have an ASAM level 3.3 Medicaid policy addressing the needs of individuals with a substance use disorder and traumatic brain injury. ASAM level 3.5, clinically managed residential. This, again, is a new service for some populations. It currently exists under Medicaid and state-funded services, but only for women and their dependent children. With this new policy, it will have 3 different attachments and address 3 different populations. This level of care will address adolescents at a medium intensity, adults at a high intensity, and then pregnant and parenting women and their children at a high intensity. Individuals needing a safe and stable living environment to develop and demonstrate recovery skills to prevent immediate relapse are appropriate for this service. Multidimensional needs are severe enough that they cannot be treated and met at a lower level of care. Individuals have significant social and psychological problems, as well as limited coping skills, and they often experience physical, sexual, or emotional trauma, and often have justice system involvement limited education, and work skills. They may have no experience living in an environment that supports healthy psychosocial development. All of these services require revised and or new licensure rules and rates. Asam 3.7, medically monitored intensive inpatient services. This level of care is currently covered under Medicaid and state-funded services. Many of you may know this as residential treatment. It will be updated to include the Asam criteria, as well as it will require a licensure rule revision and new rate model. It provides a plan and structured regimen of 24-hour professionally directed evaluation, observation, medical monitoring, and addiction treatment in an inpatient setting. Individuals do not need the full resources of an acute care general hospital, but they must meet the needs and dimensions 1 of Asam, which is the acute intoxication and or withdrawal potential, dimension 2, the biomedical, and dimension 3, which is the emotional, behavioral, or cognitive conditions. So someone may be have a withdrawal risk, or they have poorly controlled asthma or hypertension or diabetes, or they may have a comorbid mental disorder. And this level of residential includes medical staff that will address the needs presented by those 3 dimensions. Asam level 4 is medically managed intensive inpatient services. This level is currently covered under both Medicaid and state-funded services, and the Asam language and criteria will be updated, but there are no licensure or rate revisions required for this level of care. Next slide, please. So as you can tell, for North Carolina, we have chosen to utilize Asam as the evidence-based SUD-specific placement criteria. CMS required each state to identify an evidence-based criteria as a part of the 1115 waiver application, and North Carolina chose Asam, as did most states across the country. In North Carolina, this was in line with our current standards of care, clinical coverage policies, and state-funded service definitions. Next slide, please. An Asam level of care determination will be required for all comprehensive clinical assessments and diagnostic assessments completed on individuals who have a substance use disorder. This applies to providers that are in the standard plan and tailored plan networks. The CCA and DA are an important part of the process in determining the appropriate level of care. There's always a potential for assessing or recommending the services offered by the agency versus referring out to the clinically appropriate level of care. Asam criteria training is required for all licensed professionals who are eligible to bill these services. We must ensure that individuals receive the appropriate level of care, and that there is an understanding by the professionals who are completing the assessment of those levels and the appropriate risks that come along with making those determinations. It's important that the UN staff have the knowledge and understanding of Asam level of care criteria as well, in order to accurately review for medical necessity to ensure individuals are placed in the appropriate level of care. Next. Person-centered planning is a key treatment planning process to ensure individuals have the choice and that they have an opportunity to identify and address their goals as a part of treatment. Both standard and tailored plans are required to follow the person-centered plan provisions included in the current Medicaid clinical coverage policy and state-funded service definition policy prior to authorizing services. Next, please. Prior authorization. So with prior authorization, this is, I think, probably another really big change in policy for both Medicaid and state-funded services. For all residential and withdrawal management levels of care, there will be a pass-through units available. This means that when an individual has an Asam level determination for any of those residential or withdrawal management levels of care, that there will be a certain time frame, whether it be 7 days or 14 days, that an individual will be able to immediately access services without having to wait for a prior authorization decision. We want to ensure that individuals who meet medical necessity criteria are able to access crisis and treatment services as quickly as possible. We know that we lose people when they show up for services and have to wait. People seeking treatment for substance use should not encounter barriers to accessing needed treatment and care, bottom line. Next slide, please. With utilization management, DHB and DMHDDSAS are establishing prior authorization requirements for all Medicaid and state-funded services. So in respect to withdrawal management and residential, there will not be a prior authorization because there will be those pass-through units, but there will be PAs on other services. With standard plans and tailored plans, they have the authority to establish requirements that are different from, but not more restrictive than Medicaid state plan requirements. Asam states that the requirement that a person fail first in outpatient treatment before inpatient treatment is approved is no more rational than treating every patient in the inpatient program or using a fixed length of stay for all. They talk about the fact that the treatment failure approach potentially puts the person at risk because it delays a more appropriate level of treatment and potentially increases health costs if restricting the appropriate treatment that allows the addictive disorder to progress. So we are part of the 1115 waiver was to adopt a standard, evidence-based standard of care, which also includes when you have the determination of a level of care under Asam, that the individual gets access to that level of care and does not have to fail at a lower level of care prior to accessing what they need. Next slide, please. Up next is length of stay. The length of stay and residential care will be based on beneficiaries' medical and clinical needs. And we just did this presentation the other day and talked about the 28-day residential cure, which was really based on what insurance companies would pay and not on what individuals required to address the individual's medical care. So the intent with these policies is not to put an arbitrary number of days in for length of stay, but for the ASAM continued stay criteria and discharge criteria to be utilized to support an individual's medical and clinical needs as appropriate for that level of care. So the intent is that that level, that length of stay will be based on that and not an arbitrary 14 or 28 days or 90 days. Next slide, please. And we know that this is supported by research. Let's talk about length of stay and treatment engagement. With NIDA, they initiated the drug abuse treatment outcome study in the 90s to evaluate treatment outcomes and emerging trends. And over a 2-year period, they focused on intake and treatment and 12-month follow-up analysis of over 10,000 adults and individuals receiving outpatient opioid treatment, long-term residential treatment, which was 4 months to 2 years, with the average, I think, of 3 months, and then outpatient drug-free or short-term inpatient. Next slide. The length of time, surprisingly, that people stayed in treatment was directly related to improvements in their follow-up outcomes, which was replicated findings from previous evaluations. In long-term residential and outpatient drug-free, people who remained in treatment 3 months or longer had significantly better follow-up outcomes on a variety of data versus those who dropped out early. Next, please. Milestone 3. CMS required states to utilize a nationally recognized SUD specific program standard to set provider qualifications for residential treatment facilities. This is the reason why we're amending and developing the new licensure rules that will reflect the ASAM criteria. Next slide, please. The Division of Health Regulations, or DHSR, they monitor currently the compliance of licensure rules that identify program standards, service requirements, program hours, etc. But currently, the only 2 licensure rules that we have in place that really address ASAM are SAIOP and SACOT. Next, please. So the department will be reviewing and updating the existing licensure rules to reflect the ASAM criteria. And we'll be working together to develop new standalone licensure rules for some that will be brand new and some that are existing. Our division, the Division of Mental Health, Developmental Disabilities and Substance Abuse Services, and DHR, in collaboration with Medicaid and other divisions, will develop these licensure rule waiver process. And Denise Baker was going to be here to talk a little bit about that, but I will address this piece. Basically, the division of MHDDSAS's director has the ability to request from DHSR the ability to waive a licensure rule. Many of you who may recall with the SAIOP and SACOT services that there was not a 4,400 or 4,500 licensure rule back in 2005 when those services became available in the continuum. And we had a licensure rule waiver process in place where we utilized the current day treatment for substance use licensure rule and waived that rule and added in the IOP and SACOT requirements. So providers who were wanting to provide SAIOP or SACOT were licensed under the waiver, received a license that was supported by both policy and the licensure rule changes until the permanent rules were implemented in that following year. And that's the same thing that we're going to have to do with almost all of the services that I discussed earlier, with the exception of the inpatient hospital. So we're either going to be developing or revising many of the rules. And while we're doing that process, we will have a licensure rule waiver in place so that we can begin providing these services even before the permanent rules are in place. It can take up to 2 years for a permanent rule to be put in place. And so thankfully, we have the ability to do a waiver process and support these services upon implementation this year. And I think I'm turning it over to you now, Stacey. Stacey, you're on mute. Stacey, are you there?
Stacey, there should be a button popping up on your screen that's asking you to unmute. I had to mute you since we were getting some feedback.
Unmute. Can you hear me now?
Yes, perfect.
Sorry, I had to stop sharing screen to see that. So let me go back. I was just talking away.
Yeah, there was just some feedback, so I ended up needing to mute you, but I know I have to unmute you to do that.
Okay, let's see. Oh, now I got to switch it again. Okay, so all that great work that Starleen talked about with all of the policies that we're revising, all of the new services that we're bringing into the state, all of the unique aspects of these services that we're really hoping puts North Carolina in front of the rest of the country when it comes to innovation in substance use disorder. That stuff is all great, but it's not so great if we don't have capacity. So Milestone 4 looks at exactly that. Sufficient provider capacity at critical levels of care, which includes medication-assisted treatment for opioid use disorders. Sufficient provider capacity will be critical to ensuring that beneficiaries have access to the right level of care at the time they need it. Sufficient provider capacity also ensures beneficiaries don't immediately encounter a barrier when they seek treatment. Making beneficiaries wait to engage in treatment can result in them not seeking treatment and either returning to or continuing to use. Given the statistics we discussed earlier about fentanyl-related overdoses and opioid use overdoses, this can and does put beneficiaries in an extremely unsafe situation. There needs to be sufficient capacity for comprehensive clinical assessments and diagnostic assessments to be completed that render an Asam level of care determination and then link that beneficiary to that level of care. There needs to be sufficient capacity at all withdrawal management levels of care to ensure that beneficiaries have support to manage withdrawal from the substances they are using. There needs to be sufficient capacity at all residential levels of care to ensure that adolescents and adults that need a residential level of support can begin their recovery journey and they're able to access that level of care in a timely manner. Finally, we need to ensure there is sufficient capacity in our community-based care at our outpatient, SAIOP, and SACOT levels. We need to continue to measure and assess the need for and access to medication-assisted treatment to ensure that when a beneficiary presents to an OTP provider or an OBOT, they are able to immediately initiate treatment. Especially for beneficiaries seeking and needing this level of care, a delay in treatment initiation can have dire consequences. We spoke earlier to the number of North Carolinians that we have lost due to opioid overdose disorder, and also spoke at length about how we are continuing to see an increasing trend in opioid overdoses, as well as ED visits due to opioid overdose. We cannot afford for this trend to continue or to worsen. We also know that ensuring beneficiaries can continue to or start MAT while receiving other levels of care is a key component of treatment. This is why in all policies being revised or developed, we are requiring providers to ensure that beneficiaries are either that are on MAT or need MAT have access to that service while they are in other medically necessary treatments like IOP, SACOT, or other residential levels of care. We also realize that this requirement could have an impact on provider capacity, as we could see more individuals able to initiate or continue access to these services. So being mindful about MAT access and availability across the state is going to be very important in the coming months as these services come online. Standard plans and tailored plans are responsible for managing their provider network and are required to comply with time and distance standards for all Medicaid services. Both standard and tailored plans will have in their contract network adequacy expectations. Again, they typically have time and distance standards. However, we need to also be actively tracking if these providers are regularly near or at capacity. If a beneficiary lives 20 minutes from an OTP provider, but they are at capacity and have no ability to take new referrals, and the next closest OTP provider is an hour away, that is a barrier for that beneficiary to enter into treatment. Capacity is just as important as time and distance. Proximity doesn't matter if the provider isn't able to take on new beneficiaries. The department will conduct an assessment of all Medicaid enrolled providers that includes identifying what providers are currently accepting new beneficiaries. We are in the early stages of developing an assessment to identify current SU providers as well as their capacity to take new beneficiaries into their levels of care. Our intention is to use this information to have informed conversations regarding network capacity and coverage. We have also begun having discussions with providers regarding the new services coming online and the requirements and expectations for those services to begin to identify where providers would be able to set up some of the newer services, like Asam Level 2 WM. As Starleen said, we currently do not have that available in the state. However, it will be written into the standard and tailored plans with capacity with time and distance requirements. So starting to talk with other levels of withdrawal management providers about their interest and ability to take on that service, to add it to their contract, what supports they might need. We had a similar conversation with providers that have some interest in providing Asam Level 3.3, which is the Residential Substance Use and TBI program. And during that meeting, we were able to find out from them, most of them had experience in the TBI realm. They were able to share with us some thoughts and considerations that agencies and providers would need to have if they were considering adding this program to their array. If funding is available to help startup, how they would like it would be most beneficial to have flexibility in the funding. They spoke to things about the needs for ramps and adaptive equipment and technology in the homes for folks that might have a TBI that impacts their mobility. So we are also having to have discussions regarding that type of network capacity as well. Milestone 4 includes expanding access to MAT. We have approximately 2,670 Data 2000 certified providers in North Carolina. The caveat to that is we currently don't have a way to track if those Data 2000 certifications are currently being used, or if a prescriber has stopped providing that service for any reason. And we also don't know the maximum treatment capacity for those providers. This is not something currently that we can just pull a report on. We also know that as of the slide deck, there were 86 distinct OTPs licensed across the state. We do have better access to that information since DMHDDSAS houses our SOTA team, and they are very closely linked to and working with the licensed OTPs across the state. This map represents local health departments' assessment of access to MAT. So it is important to keep that in mind as we look at and talk about this map. This is not based on SOTA data or any other information that we have at a state level. This is local health departments indicating what kind of access they have and where it is. Counties in blue are where the local health department said there's at least one MAT provider that offers low to no cost services. Counties in orange represent where there is access in adjacent counties to low or no cost MAT services. And counties in red represent no access to low to no cost MAT services, even in neighboring counties. Again, this is based on local health departments' information, and it is not a map of where current MAT providers are that support Medicaid beneficiaries. While this map does indicate that currently 59% of counties have some access, it is important to note that 19 counties, or 19% of counties, do not have any data reported, and several of these counties are in rural areas. And as we mentioned before, we know that individuals in rural areas have more difficulties accessing MAT due to the barriers that they experience, either being there are no providers or the distance to the provider is such that it is a barrier in and of itself. It's also important to note that there are 18 counties, or 18% of our counties, that are in red, which indicates the local health departments have indicated they have no access to low or no cost MAT. We will be collaborating with our SOTA colleagues to map out our current OTP providers and identify counties that don't have access. And we will also be working internally to determine how we can start to better track OBOP providers to develop a more complete and accurate representation of MAT access across the state. Also under Milestone 5 is the implementation of comprehensive strategies to address prescription drug abuse and opioid disorders. North Carolina developed the first Opioid Action Plan in 2017 and has continued to update and revise the action plan routinely. Currently on its third revision, the Opioid and Substance Use Action Plan 3.0 broadens the focus of the 2.0 update to include polysubstance use and also includes considerations around equity and lived experiences. The plan focuses on the following 4 priority areas to address the opioid and substance use epidemic. They are centering equity and lived experience, prevention, harm reduction, and connection to care. The Comprehensive Addiction and Recovery Act, or CARA, was signed into law in 2016 to help address the opioid epidemic. It authorized the use of funds to address the opioid epidemic by focusing on 6 areas, which are prevention, treatment, recovery, law enforcement, criminal justice reform, and overdose reversal. The 21st Century Cures Act was passed in 2016 and also included support and funding for states' responses to the opioid use epidemic. North Carolina has participated in and benefited from this support at a federal level to strengthen and expand services and supports to beneficiaries experiencing opioid use disorder and substance use disorders. North Carolina included several opioid crisis strategies in the 1115 Substance Use Demonstration Waiver Plan, including the Opioid Action Plan, state legislation implementing opioid prescribing guidelines and expanding access to naloxone, the Medicaid pharmacy program initiatives, requirements for PHPs, and we did receive federal grants to assist in addressing the opioid use disorder epidemic. Milestone 6 of the 1115 SUD demonstration waiver is improved care coordination and transitions between levels of care. Currently, LME-MCOs are responsible for providing care coordination to beneficiaries that either have special health care needs or meet the state's definition of being at risk. A beneficiary is considered to have special needs if they are a beneficiary with a substance use disorder that meets at least Asam Level 3.7 or Asam Level 3.2 WM, if they are an adult that is using drugs by injection, if they are a child with a substance use disorder diagnosis who is in a facility, has been in a juvenile justice or correctional facility for the past 30 days, has been in an inpatient hospital setting, a therapeutic group home, or a psychiatric residential treatment facility, or individuals with co-occurring substance use disorder and mental illness that score a locus of 5 or higher, or Asam 3.5 or higher, or individuals with a co-occurring substance use disorder and IDD that score Asam 3.3 or higher. A beneficiary is considered at high risk if they do not show for scheduled appointments and are at risk for inpatient or emergency services, or they receive a crisis service as their first service in order to facilitate engagement with ongoing care, or are discharged from an inpatient psychiatric hospital, facility-based crisis, or general hospital unit following an admission for substance use disorder. The care coordination provided by LME MCOs cannot be duplicative of any care management or care coordination functions that are embedded in the service the beneficiary is receiving. The care management or the care coordination can include identifying clinical needs, determining level of care through case review, linking for psychological, behavioral, educational, and physical evaluations, addressing support services and resources, monitoring attendance and treatment, and coordinating and linking all Medicaid-funded services. LME MCOs are also currently required to coordinate care and monitor services when beneficiaries are transitioning between levels of care. They assist with discharge planning after long and short-term hospital stays when admission is due to a behavioral health diagnosis. These services should include natural supports and cannot be duplicative of the discharge planning requirements the facility is required to meet. Upon tailored plan implementation, which again will happen December 1st of this year, standard plans and tailored plans will be responsible for care coordination and care management for enrollees with substance use disorder, and this will include managing transitions between levels of care. For standard plans, enrollees diagnosed with a substance use disorder meet the state's definition of special health care needs and are a high priority for receiving care management. This will include transitions from one clinical setting to another, and they'll be managed by the standard plans to prevent unplanned or unnecessary readmissions, ED visits, or adverse outcomes. Standard plans must have transition of care policies and procedures. Care coordination can include developing policies and procedures for coordination between physical and behavioral health providers and between mental health and substance use providers, establishing policies and procedures to coordinate transitions from LME MCOs to Medicaid fee-for-service to standard plans, from one standard plan to another, or between systems. Design of an evidence-based tool to conduct a care needs screening that identifies behavioral health needs and incorporates the Asam criteria to screen for substance use level of care need, making best efforts to conduct a care screening of every enrollee within 90 days of enrollment as required by the managed care rule to identify unmet healthcare needs. Care coordination activities must address physical health, behavioral health, pharmacy, and social service needs. Tailored plan care coordination and care management will support enrollees with complex needs and high-cost services and the need for robust whole person care management services that address physical health, mental health, substance use, IDD, intellectual and developmental disabilities. My apologies for not spelling that out before using it. TBI, which is traumatic brain injury, pharmacy, community support, and social needs. TP care management will be more intensive than the care management provided to enrollees in the standard plan, and TP care management will meet the federal standards for health home services. TP enrollees will be more closely engaged with mental health, substance use, IDD, and TBI providers, and should receive care coordination at these locations or in primary care settings. Care managers should have experience and expertise working with beneficiaries that have complex and significant behavioral health and IDD needs. Care managers should also have experience managing physical health comorbidities and also have experience supporting the coordination between physical care and behavioral health care systems. Services should be delivered face-to-face for TP enrollees. TP transitions of care are required to provide comprehensive transitional care management services covering all the standard plan transitional care management services, in addition to instituting evidence-based care transition programs directed toward enrollees with mental health, substance use, and IDD, and developing relationships with local hospitals, nursing homes, substance use residential facilities, and inpatient psychiatric facilities to promote smooth transition. This also includes supporting the transition of care across plans to support quick and fluid care transitions. And that is the final milestone of the 1115 substance use demonstration waiver. Our next slide has our contact emails on it, and I will pause on this so you can write them down. We are also going to make these slides available. I believe next week is when they're going to send them out or post them on the website to access them. And it looks like it's 11:30, so I'm going to hand it back to Amanda, I believe.
Great. Thank you, Stacey and Starleen, for that very comprehensive overview of all the milestones within the 1115 waiver. We do have quite a bit of questions, and I think we have some time to address those. So I'll go ahead and read that out. And just to reiterate what Stacey was saying, I know there was some minor feedback, audio issues, so we apologize about that, but the slides will be available within the next week. So I will just go through the questions as they came in, and the first one we've got is we are developing a predictive model for the effects of Medicaid expansion on overdose deaths in North Carolina and looking for an estimate of how much Medicaid will cover medication-assisted treatment, including methadone and buprenorphine. Do you have any information on that?
So we might. Medicaid does cover the opioid treatment policy as well as the office-based opioid treatment provider policy as well. So if a person has Medicaid as their insurance, it would be covered. But I feel like that's not the question you're looking for. Perhaps you're looking for more of a this percent, we anticipate this percent of Medicaid beneficiaries have opioid use disorder and would qualify for OTP and OBAT, and of that, how many would get coverage? Is that kind of what you're looking for?
If the participant that asked that question wouldn't mind putting a response in the chat, that'd be great on what the exact needs are.
How about having them just email you directly, Stacey?
Yep.
Yeah.
Sounds great. So for the sake of time, we'll keep it moving. The next question we got from Katie is, I manage a MAT program within a federally qualified health center, and one barrier we have encountered is difficulty getting medication through pharmacies. With increased access to MAT and prescriptions for maintenance medication, I anticipate even more difficulty getting medication through pharmacies. How is this going to be addressed on a systemic level?
So that is a good point, and something that we've actually already had providers reach out to us and let us know that they are experiencing barriers with not necessarily getting the service, but getting the prescription filled. And what we have done on our end is when those cases come up, we're reaching out to the pharmacy team at Division of Health Benefits to let them know about the access issue and to see If it's something that there's a barrier or a block on our end, they're also able to reach out to some of the pharmacies and try to figure out what the issue with accessing the medication is. But I would request if programs are experiencing a barrier for individuals accessing the medication that's being prescribed to them, to shoot me and Starleen an email so we can flag it, track it, and forward it to our pharmacy team and raise awareness to them. Starleen, do you have anything else to add to that?
If I could add just one more thing, I think that's a great response. This is an issue that has been ongoing for a little while that we're fairly aware of. And since Stacey mentioned, we've been working with pharmacy teams, and on a training and education standpoint, our Division of Public Health has been contracting with the North Carolina Association of Pharmacists to put out really direct training on, how to expand access to medications for opioid use disorder, specifically buprenorphine, and how to address some of the barriers and stigma that come up in a pharmacy setting. So please reach out to us as this comes up.
So you've got 3 people to email.
Yes, and I will put my information in the chat at the bottom as well. The next question we got is from Randy. So his question is regarding a bill in the Senate, H1 49. I'm not sure if you all are familiar with that, but is asking if that would adequately provide for mental health or substance use disorder treatments. And he put the link to the bill, if that's helpful, or if you want to answer offline.
That's helpful. I have not had a chance to look at this one yet. We've been looking at some other bills that have been. Starleen, have you seen this one yet?
And I think it might be one of the expansion bills.
Okay.
Can we answer this one offline?
Yes. All right, Randy, we'll get back to you. The next question is from Glenn. Does lifting the 28-day max include the state ADACs?
So it will include, I'm trying to think of how to, so it will apply to services that are following and billing clinical coverage policies. So in this case, if the state ADATC is working under clinical coverage policy 8B, which is our inpatient services, and they're providing either Asam level for the medically monitored intensive inpatient or medically monitored intensive inpatient withdrawal management services, then yes, the IMD would be excluded. If they are not working under a clinical coverage policy, or if they're providing services for a mental health reason, then IMD is still in place for the folks with a mental health diagnosis that are needing inpatient treatment. And that actually applies to all mental health services. IMD has not been waived for any of those services at this time. Starleen is going to say something.
So the whole 28-day max piece, you have to take that in perspective with the level of care. So if you have an inpatient, a person who goes in for inpatient hospital services, that the continued stay is what is also going to guide the length of time someone's in there. So they still have to meet medical necessity to continue to stay in that service. So for a hospital level of stay, it's likely only going to be, 5-7 days of care, and then they're going to step down into a lower level of care. So Asam was created, and the intent of Asam is to be fluid and for folks to be in the right level of care, receiving the right dosage of care for what their needs are. So I don't want folks to get confused that somehow, someone's going to stay in a detox level of care for, 3 months, and that they need to be moving into the next appropriate level of care. So for ADACs, their primary service is a hospital level of care, that 4 and 4WM. And then they, also provide some of the lower levels of care, but it really depends on what level of care that person is receiving. So I just wanted to say that piece.
Thanks, Starleen. I think we have time for one, maybe two questions. So this question came in: will there be a review of the LME-MCO policies regarding who will they accept into their network? For example, some LME-MCOs are closed networks, and despite the need for certain licensed providers, especially in resource-poor areas, the network remains closed, causing limited access to care because of long wait times to be seen.
So that is a good question. And it kind of has, so the LME-MCOs, future tailored plans and standard plans, do have the authority to manage their provider network. That is something that was granted to them through Medicaid transformation and the waivers that are in place. However, we will be looking at network adequacy. And as we said, part of adequacy isn't just, do you have a person within a distance? It's also, is that person actually taking referrals? And how long are people having to wait to enter treatment? Through this waiver, we'll be able to do a closer look at those substance use services, the wait times, and be able to have some discussions around, is there a need for expansion, either that one provider that's always at capacity, maybe seeing if they could if adding staff would allow them to add more slots, or is the need such that maybe we need to consider adding a provider that's adjacent to, maybe not right on top of that other provider. But regarding the actual policies of who they let into their network and how they do that, I don't think that's something that we will be able to impact at that level, because that is an authority that they have currently and they will continue to have. I don't know if there's anything to add on the DMH side.
Great, thank you. And we'll take this one last question. If anyone else has any questions, feel free to put them in the chat and we'll make sure that Starleen and Stacey get them after this meeting. So the last question that has come in is, what does this all mean for incarcerated individuals as far as getting them started on treatment? The considerations there.
Okay. So, oh, I see Starleen, you're unmuting. Do you want to take this one?
Sure. So, as a part of re-entry, there's lots of things that are happening around incarcerated people in terms of accessing care when they're coming back into the community. Some of the substance abuse prevention and treatment block grant supplemental funds that we have available are being utilized to help individuals who are coming into the community. And so I think with Medicaid, that their Medicaid, if they are Medicaid eligible, that then becomes available again once they are out of incarceration, once they are post incarceration. But I think for state funded, for those who don't have Medicaid, that we are working with the Department of Public Safety on means of accessing services, helping people access services when they re-enter the community. So I think, any of these services that an individual might meet medical necessity for would be available to them as a part of that re-entry plan.
Great. Thank you both so much for your presentations and overview. And at this point, we're going to transition just a little bit to our next presenter, Kimberly Kennedy, who is a nurse consultant with North Carolina Medicaid, and she's going to talk to us just briefly about transportation. Kimberly, I'll pass it to you.
Thank you, Amanda. Let's see if I can share my screen. Can you see them yet?
Not quite. And if you need us to share, just let us know.
Okay.
Kimberly, if you click on if you're seeing the Zoom screen, if you click the green button at the bottom, it says share screen. And as long as you have your PowerPoint up in your background, you should be able to see that as an option. So if you just click share screen and then PowerPoint. Perfect.
Very good. So I'm just going to give you a little overview of the NEMT non-emergency medical transportation benefit. Okay. NEMT is a critical covered benefit for North Carolina Medicaid beneficiaries. It allows them to access healthcare services from Medicaid providers in both North Carolina Medicaid Managed Care and North Carolina Medicaid Direct. NEMT services consist of arranging and paying for transportation that's medically necessary, as well as travel-related expenses. NEMT transportation providers include public transportation, taxis, vans, and non-emergency ambulance transportation. So Stacey and Starleen both mentioned transportation and why is NEMT important. Studies show that offering NEMT to beneficiaries to access behavioral health services, preventative health services, and care for chronic conditions and other disadvantaged populations can remove transportation barriers that can be social determinants of health. And other examples of social determinants of health are like food insecurity and housing instability. And helping to remove those barriers can have a positive impact on overall health. NEMT is also important to prevent missed medical appointments, decrease the impact of chronic disease, and reduce the cost of inpatient medical treatment. This slide just gives references to support the previous slide, and one study estimated that 3.6 million people miss or delay medical care each year because they lack affordable transportation. The study found improved access to NEMT for this population is cost-effective for the medical conditions analyzed, such as prenatal care and chronic conditions such as asthma, heart disease, and diabetes. Another study found that adults who lack transportation to medical care are more likely to have chronic health conditions that can escalate to a need for emergency care if it's not properly managed. The North Carolina Department of Health and Human Services key transportation priorities include a commitment to ensure beneficiaries have access to a strong system of transportation providers in the NEMT program, including community transportation programs. The department supports partnerships between the prepaid health plans, their contracted brokers, the Division of Social Services, the Department of Transportation, NCPTA, or the Public Transportation Association, and providers to meet this goal. NEMT is crucial to ensuring Medicaid beneficiaries have access to appointments to help manage chronic conditions, receive life-sustaining treatment, access behavioral health services, and medications. We continue to leverage the existing system to build off what is working now. PHPs are required to provide coordinated, timely, safe, clean, reliable, medically necessary transportation, provide NEMT that's appropriate to the member to the nearest enrolled medical provider. And some examples of the travel-related expenses include lodging, food, parking fees and tolls, transportation vouchers, and mileage reimbursement. The PHPs are also required to develop a network of NEMT providers. Members began receiving NEMT services through the health plans July 1st of 2021. Members enrolled with the PHPs called their health plan or the health plan broker directly to request the transportation. DSS offices continue to provide NEMT services for beneficiaries in the North Carolina Medicaid Direct program and for the ECPI travel option. NEMT brokers contract with both private and public NEMT providers, and in the table at the bottom, the health plans that contract with the brokers are listed underneath. So the two brokers are Motive Care and MTM. And on this page, these are the NEMT contact numbers. And as they said previously, these slides will be posted, so you'll have that information. And then this slide just gives some statistics. Like in the first row under measure, it's a one-way trip legs completed per month. And like a trip leg is from the member's home to the provider. And then the second leg of the trip would be like from the provider to the pharmacy. And the third leg would be like from the pharmacy back to the member's home. So, so that just gives you a reference of what that number is. And as you can see, there's been increased utilization significantly since launch in July of 21. And also you'll see that Motive Care and One Call are listed as the brokers here, but One Call left the network, and so MTM as of May 1st is now the broker for WellCare. And some NEMT challenges and opportunities have been, well, the challenges have been ensuring that there are enough providers available to serve beneficiaries, accommodating trip requests at short notice, provider training on the new broker systems and operating models, and the impact and response to COVID-19. Opportunities include that North Carolina has a strong network of county public transportation providers. The brokers have strengthened their relationships with the NCPTA and able to use the lessons learned during the launch of the standard plans to help strengthen the NEMT benefit for the tailored plan members. So is there any questions?
Thank you, Kimberly. Feel free to put your questions for Kimberly in the chat. I saw one of my colleagues just put a comment, transportation access is life affirming, and that's so true and so important. So appreciate you taking the time to share today. One question that's come up is some members may need a parent, guardian, or friend to accompany them to the appointment. Would they be able to ride as well?
Yes, members who are under 18 or that have special needs are able to travel at no additional cost, and it doesn't have to be the parent. It could just be a family, friend, or neighbor. .
And then you had said that accommodating trips on a short notice is a challenge. How far in advance would someone need to call for a ride?
Okay, members should make their request as far in advance as possible, but at least 2 business days before the appointment, they need to call ahead. And if it's a long distance trip, they need to call at least 5 days ahead. And there are exceptions for urgent trip requests.
Thank you. Other questions for Kimberly? Haven't seen anything come through. If anything comes to mind, even after this meeting, feel free to reach out to us and we can make sure that these questions get to the respective speakers and you get an answer. So just wanted to thank everyone again, our panelists and everyone who participated today for your active participation, both in the chat and throughout the discussion. So as a reminder, we're gonna post the meeting agenda, the recording, and the PowerPoint on the OPDAAC website within the next week. Sarah is just pulling up the last slide here, and that link there will take you to our OPDAAC landing page where you can find all the previous agendas, PowerPoints, and recordings for the past several years. So our next OPDAAC meeting will be held in September. We hold these on a quarterly basis. We are still determining what that will look like, if it'll still be virtual, in person at the McKimmon Center in Raleigh, or a mix of both in some type of hybrid format. So we will certainly keep you all updated once that date, location, and topic has been finalized. If you're not already on our listserv to get those updates, feel free to reach out to myself or Sarah and we'll make sure that you're added. So just wanted to thank everyone once again for joining on this Summer Friday and hope everyone has a great weekend.